Yes, sir. So good evening to everybody. The 36th the master class on behalf of the Indian Society Hematology of the Blood Transfusion. So this session is by our eminent teacher and also the pioneer in the one of the pioneer in the bone marrow transplant in India, none other than Professor Rajat Kumar. Dr. Rajat Kumar currently in the Princess Margaret Cancer Center in the Toronto, and he has vast experiences in the field of the transplant, and he has a transplant lead of elderly in the Princess Margaret Cancer Center. So we'll hear from Professor Rajat sir regarding this, the elderly stem cell transplant, which is basically a new area for the hematologist. So with this brief introduction, may I requesting sir, you please start your deliberation.
Thank you, Dr. Dulai, and thanks to ISHBT and the college for this opportunity. So, as I've been asked, I will talk about allo blood and marrow transplant in the elderly. Can we transplant safely? So, my objectives are to discuss the vulnerabilities of older people when they undergo hematopoietic cell transplant. I will spend a fair amount of time discussing assessment of frailty in our routine clinics. And then I'll touch on the optimal strategies to improve outcomes of transplant, although I will be very brief because time is kind of limited. So, firstly, what are the challenges when we transplant the elderly? We all know that they are likely to be frail or pre-frail. With age come comorbidities. They may have less motivation to undergo the stress. And when people are ill and they are older, they get disoriented much faster than younger people. And they may have less caregiver support. At least in Canada or in the West, family size is limited. Very often people are alone or they have just a spouse and they may be the caregiver for their spouse. In India, I know it's different. You have large families, but now as people move away, often, older people are alone. Now, what is frailty? I think it can be shown in a diagrammatic manner here. It's a state of extreme vulnerability to stress with adverse health outcomes. So basically, there's reduced physiological reserve. So if you see a fit person and if there's some stress, they are, their systems are impaired, but they bounce back very quickly. They are resilient. If they are very frail, they will not adapt that well, will not be so resilient, and pre-frail is somewhere in between. I think we all know what I'm saying. As a child, if you fall down or you see a young one, they just jump up and start running. But as we get older, if you fall down, then you'll have aches and pains and take longer. So imagine the same thing happening with something like transplant. Now, the age at which these many diseases are diagnosed, like AML, MDS, myelofibrosis, is in the 60s, at least in the West and even in India as the population ages. And the only way we can cure these diseases is by an allo hematopoietic cell transplant. Now, we have medicines, but they are not curative. So either you continue for a long time till response ends. And if you look at the cost, many of the medications for AML, like venetoclax or for myelofibrosis, they are very expensive. So in the long run, they are not economical. If we look at the profile of patients undergoing transplant in the US and focus on those who are between 65 and 74. So in 2012, it was 12%, and now it is 25%. So that is huge. Sorry. Okay. You can hear me still, right?
Yes, sir, we can hear you.
Okay. I was trying to remove something, and that's why I was a bit confused. So in 2022, 3% were more than 75 years of age. Now, if you look at the Indian life expectancy, in the 1950s, it was quite low. But now, in 2024, it's 70 years plus. And I'm sure we all know people rather, not patients, who are in their 70s and 80s in apparently good health, with good insurance, financial support. And if they come with such a disorder and they say, well, I want a cure, they know the latest, they've Googled, and can we say we will not transplant you because you're old? So let me start with a case. This was a 64-year-old man I saw here, acute myeloid leukemia with complex karyotype and TP53 mutation, one of the worst AMLs. He started with chemotherapy, and as expected, there was no response because these patients don't respond to chemo. He then got decitabine and venetoclax and achieved CR. He was then referred to me for transplant. Now, he was very fit. When I mean very fit, he was running 10 to 15 kilometers a day, doing weightlifting, very alert, working. So I discussed with him the risks, benefits, risk of relapse, transplant, and he said, yes, please go ahead. So we gave him myeloablative conditioning, Flu-Bu-4, which normally we don't give at this age. Gave him normal, ATG, methotrexate, cyclosporin. He had a mud donor. He engrafted, no problems. He had mild chronic GVSD, but then at 8 months he relapsed, as expected. And then he got again decitabine and venetoclax and achieved a second CR. And then the question was, do we do a second transplant? But by now he is 65 years of age. So I'll come to the case later, but let's review the data. Now, an expert panel in ASCO had mentioned, and this was published, I think, in 2018, that in people who are 65 years or older receiving chemotherapy, they need a geriatric assessment to identify their, vulnerabilities which are not routinely captured. And this information should be given to the patients and caregivers before any decision is taken, whether to give or to deny treatment. And this is just to show one part. This study, they compared after transplant overall survival in patients who had no comorbidities and normal instrumental activities of daily living. By that, I mean complex tasks. So those who had both being normal, survival was more than 50% at 3 years. If one of them was abnormal, it was less. And if both were abnormal, it was very low. In other words, these abnormalities independently provide guidance on prognosis. A general guideline, and this was published in 2017, shows a few parameters listed here, and I'll just name some of them. So age, less than 66, between 66 and 75, more than 75. Comorbidities. So I think we all know what is hematopoietic transplant comorbidity index. So 0 to 2, 3 to 5, or more than 6, or severe dysfunction. Similarly, performance status 90 to 100%, 70 to 80, less than 70. And very important, instrumental activities of daily living. Those are complex tasks, which I'll come to later. Normal, some limitation, or any limitation plus some other comorbidity present. Physical performance tasks. Now, again, they mentioned timed up and go test, 4-meter walk test, grip strength, cognition, other factors. So based on that, those who are fit, they are fit for transplant. If they have some abnormalities, it is some kind of vulnerability. And if when one of these factors is present, generally we exclude them. Okay. So I looked at our own center data because I moved to Toronto in 2018, and I looked at people who are old, that means older than 65, and their survival at 1 and 2 years was not very good, about 51% up to 69, and over 70, only 36%. And the transplant-related mortality for those more than 70 was 48%, whereas for the, less than 70, it was 28%, between 65 and 69. Now, this is pretty high because the non-relapse mortality should ideally be less than 20%. So it meant either the selection was not proper or the transplant was too toxic. And that motivated me to do something about it. And that's how we implemented the Frailty Project. So basically, I did a lot of review of literature, consulted my geriatric oncology colleagues, and decided to adopt tests which we could use in our routine clinics within our normal resources without extra waiting time. So let me just add, good geriatric assessment takes at least 1 hour or longer, and you need training in geriatrics. But we all know our clinics, they are very busy and no one has time. So we selected those tests which are simple to perform. And that's where we implemented this assessment. Now this presentation, the color slides are because my nurses used it in their conference, so I'm using the same slides. And in summary, this is what we decided to do. Frailty by Rockwood, I'll come to that. Function by Lawton. 2 objective physical performance tests, grip strength and timed up and go test. A self-rated health questionnaire, history of falls, mental, function, minicog, and 2 biochemical tests, CRP and albumin. The way it's done, it takes only 5 to 6 minutes. Let me expand on that. So there's a way to judge frailty. This is a very validated test. Thousands of these have been done in the geriatric population, not so much in the transplant population. And I'll explain what it is. So there's a scale developed by Dalhousie University by Rockwood, classifying people into very fit, well, managing well, and so on till they're terminally ill. And it's an impression a person, a doctor forms by the time they finish the examination. So very fit are those who are very robust, activated, exercise regularly, fittest for the age, the kind of patient I just described earlier. Well are those who have no active disease, they exercise sometimes, not all the time. Managing well are those whose medical problems are well controlled, but are not very active apart from walking. And then we have different degrees of vulnerability. Terminally ill is when we expect them not to survive more than 6 months. And obviously, people at this category are not really, patients for transplant or chemotherapy. What is function? There's a term, instrumental activities of daily living, which are more complex than normal eating, drinking, and so on. And I'll give some examples. Can you use the telephone? So a doctor, asked the question. So if someone can do without help, there's a score of 2. With some help, score of 1. And if someone is...
You manage. I'm sorry. Here, you manage.
Okay. I can hear some voices. So similarly, can someone go out of walking distance without help? For example, drive a car, travel alone, use a bus or taxi, need some help or unable to travel, and so on and so forth. So there are 7 domains and a doctor will score. So if someone is doing very well, they'll get a score of 14. If they have impairment, the score will be less. Now, I understand this has some social and cultural relevance. For example, in India, someone would say, I don't prepare my meals, someone does it for me. I don't go shopping, I just order, Uber or someone else to do it. But even then, we can design it to know, is a person independent or needs help? Next, grip strength. So this is we adopted because it's very objective. Using a hand dynamometer, patient will press and you see how much strength they have. And again, there are thousands of patients in the geriatric age group. Poor grip strength correlates with higher mortality, increased hospitalization, increased morbidity. Very simple to do. Another test is timed up and go test. So patients are instructed to get up from from a chair, walk 10 feet, return and sit down. So it measures their kind of energy, their robustness, and also a bit of coordination and comprehension. And the reason why we adopted this, because we could do it in a clinic room. The size of our room is about that much. So in a safe environment, they could do it. Now you can also do a walk test, walking on the corridor, but we thought it's too complex because, if they fall down or there's a crowd, it'll be a bit risky. So we adopted this test. I was advised to use a self-rated health questionnaire by my geriatric colleagues. Very simple, takes a few seconds. So a patient will say, in general, compared to other people of your age, would you say your health is excellent, very good, good, fair, or poor? And now you may think, what does this mean? But there's a lot of data that people who say they are excellent do much better than people who consider themselves to be fair or poor. And it probably reflects their own, self-confidence, depression, caregiver support, and basically ability to undergo complex procedures. There's another question we added. Have you had any falls? Very important, because if someone has had falls, it's a red signal that there's some danger and they need attention. And finally, based on a lot of studies, we adopted two tests: C-reactive protein more than 10 milligram per liter, which is considered abnormal, or serum albumin less than 35 grams per liter. Again, this may change according to different labs, but they correlate with poor outcome if they're abnormal. I won't go into Mini-Cog because we didn't use it in our scoring system. We can discuss it later. And based on 168 patients, we found that certain abnormalities correlated with overall survival. Now, this is not only in elderly, this is in all transplant patients, but our median age of transplant at that time was 58. So timed up and go less than 10 seconds compared to more than 10 seconds, overall survival was inferior in those with abnormal timed up and go test. High CRP level correlated with poor overall survival, significant p-value. Low serum albumin, same thing. So these three parameters were very important. And then we looked at non-relapse mortality. And the self-rated questionnaire, where the patient says, I'm excellent or good or fair, those who thought they were excellent did better and had lower non-relapse mortality than those whose self-rated health, scoring was low. Similarly, timed up and go tests, those who had prolonged had higher NRM. Abnormal grip strength, that means low grip strength for the sex and, again, higher NRM. And high CRP and low serum albumin, again, higher NRM. Now, another question which was asked, does this apply to young people or is it only for old? And interestingly, in young adults and older, there was the same correlation between those who were considered fit, pre-frail, or frail, because even young people, once they've got chemo, can have impairment. And then as we had more patients, about 300, we decided to see if we could create a scale, a frailty scale. So using the parameters I've just shown you, we gave values, the weightage depending on how much they correlated with overall survival. So just to give an example, clinical frailty score 3 or more, which was considered poor, versus 1 to 2. So 1 to 2 is normal, and abnormal, the weightage was 1.5. Looking at timed up and go strength, normal 0, abnormal 1.5. Albumin, normal versus abnormal, weightage 1.5. CRP, weightage 2. So adding them all together, the highest abnormal score was 10.5. And we could define patients into fit, where the score was 1 or less, pre-frail, score between more than 1 and less than 5.5, and frail 5.5 or more. And this correlated with patients being classified into fit, pre-frail, or frail in our training cohort and validation cohort. And similarly, the non-relapse mortality was highest in the frail, lowest in the fit, both in the training and validation cohort. Now, again, you may say, well, this sounds too complicated. We don't have all the equipment. But if you just look at those parameters with high weightage, like clinical frailty,
Please mute them.
okay. So if we look at the weightage of certain parameters like clinical frailty scale, timed up and go test, albumin, CRP, all these can be done anywhere. You don't have to get a proper scale, but these are parameters which are kind of, warnings that the patient is not that fit. So based on this, we decided to do a rehabilitation program for patients by identifying those who are pre-frail and building them up by exercise, access to a nutritionist, dietitian, using physiotherapy, occupational therapy, educating them, advising their caregivers, avoiding unnecessary dietary restrictions, avoiding certain medications which can impair their performance, and taking steps to optimize resiliency. And now we have funding to actually implement it as part of the program. But I'd like to draw your attention to this excellent publication present in Blood Advances 2019, where in Chicago they established a transplant optimization program, or TOP, to improve outcomes in older people and to measure and evaluate resilience. And they individualized this program for people who are older, undergoing transplant, that means 60 years or older. And they used the whole team, quite complex, including the transplant physician, geriatric physicians, ID specialists, nutritionists, social work, and so on. And they classified patients into those who could proceed for transplant, where one would decline because it's too risky, or defer and try to build them up. And these are the outcomes, the probability of survival before this program, initially when they started optimizing outcomes, and modern, and they improved survival from around 40% to around 70% at 1 year. And their non-relapse mortality, which was very high, similar to what I mentioned in my initial slide, over 70, it came down to around 28%, just to show that with proper selection and counseling, one can actually improve outcomes. So now let me switch gears and go to more specific, transplant-related topics. And I'll be a bit quick because each topic could take an hour. So I'll focus on conditioning, GVSD prophylaxis, donor choice, and maintenance therapy. So we all know what is conditioning. That's the treatment we give before we infuse the stem cells. And in general, patients who are older should get reduced intensity conditioning, not myeloablative. The agents depend on the kind of disease and the protocol the transplant center uses. Now, I'd just like to focus on triosulfan, and I know you're using it for thalassemia, for example, but there's increasing literature that in the older people, this has favorable outcomes compared to some of the agents we have been using. So this is a trial published in Lancet Hematology, a multicenter trial where they compared triosulfan fludarabine compared to busulfan fludarabine, and the event-free survival and the overall survival was better with triosulfan compared to busulfan. This is another study from the EBMT showing, again, flu-trio had better outcome compared to reduced intensity or myeloablative conditioning. So again, triosulfan is a very good agent. And in our own center, Ivan Pasek, who's our young faculty, compared outcomes using flu-trio compared to flu-busulfan, and graft failure was the same, but the overall survival and the relapse-free survival was better with flu-trio, very, very significant. So now we have stopped using busulfan in the older group if they have MDS, and we have got funding for that. One limitation we have in Canada, we can't use any agent we want. It has to be approved by the public payer. Patient don't pay, the funding comes from the government. And this is another study. This is on myelofibrosis. Interesting. They compared triosulfan in patients with primary or secondary myelofibrosis and compare it to busulfan high dose, that means 6.4 or more, or low dose 6.4 or less. And they compared different doses, usually about 30 milligram per meter squared. And in general, the triosulfan cohort had better overall survival compared to high dose busulfan and trend towards reduced intensity busulfan. Better progression-free survival, lower non-relapse mortality, and similar relapse incidence. So I would suggest triosulfan is the agent for elderly people, at least for AML, MDS, and myelofibrosis. So let's now switch gears to donor choice. So I know we have three options: HLA matched sibling donor, classically the donor of choice, matched unrelated donor, or a MUD donor, or a haploidentical donor. In general, in each group, the younger age is preferred. But keep in mind, for old patients, their siblings will also be old. And here there's some controversy. That's why I want to address this issue. So there's a very good study published in Blood Advances, 2024, where they looked at the impact of donor characteristics on outcome on transplant using machine learning after unrelated donor transplants. And they considered, the outcomes compared to an 18-year-old donor. And the only significant donor factor associated with overall survival was age of the donor. So there's a zone of indifference where overall survival at 3 years did not differ by more than 1%, shown here. So those are people up to the age of 30. But beyond that age, when the donor age was more than 30, there was increasing mortality and reduced overall survival as the age of the donor increased. And that is why one of the recommendations is, in unrelated donors, use the youngest donor. If you look at haploidentical donors, and this is a study from Johns Hopkins, they've got a lot of experience with haplotransplant. So they used their cohort using bone marrow as a source, non-myeloablative conditioning, and PTCY, having almost 900 patients. And again, increasing donor age by each decade, there was poorer survival by about 5%, and especially in those who were more than 65-year-old patients. If the donor age was less than 30, survival was better compared to those who are older haplodonors. So the youngest adult-sized donor should be preferred when multiple haplodonors are available. For example, you may have a haplo brother who's 60 years or a haplo son or daughter who's 20 or 25 years. So use the younger one. Now, a bit of controversy. This is a study in a very good journal, JAMA Oncology, CIBMTR data. They looked at allotransplant using older matched sibling donor with donor age 50 years or more, and younger matched unrelated donor with donor age less than 35 years. And they had large number of patients, and what they found that disease-free survival was better with unrelated donors compared to matched sibling donor. And so this has been used to say, if you have a choice, use an unrelated younger donor. However, there was lower non-relapse mortality, lower chronic and acute GVHD with older matched sibling donor. So there was no difference in overall survival. So the way I see it, there's no big advantage because one advantage is counteracted by the other, disadvantage. And interestingly, this is a paper which came out just last year from Boston, Dana-Farber, almost 500 patients using the same parameters: match-related donor, donor age 50 years or more, younger MUD donor less than 35 years, similar overall survival, similar progression-free survival, similar non-relapse mortality. In other words, either donor is acceptable. At our center, we also decided to look into it, and this was published in 2023. We had about 377 patients. We took matched sibling donors more than 60 years, in other words, brothers or sisters, matched unrelated less than 30 years, no difference in overall survival, no difference in relapse-free survival. And so we always have this controversy, and I prefer, if we have a fit matched sibling donor, use them because it's convenient, easy access, and cost should also be considered. If we look at myelofibrosis, moving diseases, this is a CIBMTR study, more than 1,000 patients. They compared matched sibling donor versus MUD donors versus haplo, and the matched sibling donors are shown in red compared to haplos, MUD, and so on. Overall survival best with matched sibling donor, graft failure least with matched sibling donor, and non-relapse mortality least with matched sibling donor. So, in the elderly, if there's a matched sibling who is fit, obviously they have to be fit, that, in my opinion, is the first choice. Otherwise, matched unrelated donor, second choice, and younger donors are preferred. And the haplodonors are third choice, but might be second choice if they are immediately available. And again, younger ones are preferred. And there are factors to consider: cost. So in Canada, if you use a matched unrelated donor, the cost to get that product varies from $30,000 to $40,000. That's what the transplant registry charges. Whereas for a related donor, there's no cost. If there's an urgent transplant, a related donor will be available maybe within 2 weeks, 3 weeks. For the unrelated, it may take much longer, and meanwhile, the disease may progress. And if we need donor lymphocyte infusion, it's much easier to get the related donor. May not be that easy for an unrelated donor. So keep this in mind. And the reason why I'm spending time, because if you read literature, someone will say unrelated is better, but that is not really true. Okay, a word about GVHD prophylaxis. So I know there are different protocols. I'll just mention that post-transplant cyclophosphamide-based prophylaxis is well established for haplotransplant, but now there's increasing evidence that it is also recommended for all donor type transplants. And I'll just mention this study published in JCO last year. Very good study, more than 10,000 recipients, and the indications AML, ALL, or MDS. Mean patient age 60 years, so it applies to the elderly. And in the matched unrelated donor transplant, overall survival with PTCY-based prophylaxis was improved compared to the old, calcineurin inhibitor. So with the MUD PTCY, it was better than with CNI-based. Similarly, the Griffiths graft versus host disease-free, relapse-free survival was better with PTCY compared to CNI-based, both for MUD and mismatched. And the GVSD with PTCY was better compared to CNI-based in unrelated transplant. So, if possible, provided the patient can tolerate post-transplant cyclophosphamide, that regimen is better. And finally, a word about maintenance therapy. And this again is a bit controversial, so let me spend a few minutes on this. So after transplant, patient is in remission. If they are in complete remission, even molecular remission, no evidence of any relapse, and we give treatment, we call it maintenance therapy. If they have some kind of, measurable residual disease, then it's preemptive because now we know transplant relapse will occur. And if they have actual relapse, that's treatment for relapse disease. So the problem with maintenance therapy is we don't know if a patient will actually relapse. So if we give maintenance, we may be over-treating the patient and we may have unnecessary toxicity and cost. So if we talk of maintenance, we must counsel the patient to tell them about risk and benefit. The risk is the side effects, the cost of whatever we are doing. The benefit is we may be able to delay relapse in those who would, relapse. What is the rationale? The rationale is we want graft versus leukemia to develop, but that takes a few months, especially when we give reduced intensity conditioning. It can take 3 to 6 months. In the meantime, relapse may occur. And in the elderly, if relapse occurs, frankly, there's nothing else to do. So it buys us time. Now, if targeted therapy is possible, then maintenance is easier. For example, if BCR-ABL is positive, let's say in ALL, use a tyrosine kinase inhibitor, whatever is possible. If FLT3 mutations, ITD or TKD is positive, we can use sorafenib. There's data that sorafenib actually prolongs survival. With gilteritinib, it's a bit controversial. We can discuss it. If we have an IDH mutation, we may or may not use one of the inhibitors. And if we don't have any agent, people are using hypomethylating agents like azacitidine or decitabine. And if there's a trial, and I know there are not many trials in India, but like there was a trial recently using azacitidine plus venetoclax, we don't have the results of that. Hopefully, we will know in the next ASH. How long to give? Again, no one knows. Empirically, I'm saying about 1 to 2 years, because by that time, if there's no relapse, hopefully the graft versus leukemia effect would have taken over. One must also realize in the elderly, there is an expected decline in most functions after transplant, much more in the older people than in the younger. And it's important to counsel and prepare patients and families. Now, why this is important? Because often people think, you've done the transplant and now everything will be fine. In fact, people think the moment you infuse the cells, now it's over, transplant is done. And when the counts recover, they think now you should be bouncing back because, on Google, you'll find that stem cells restore everything. Not true. So I just want to share this. This is a prospective study of 148 patients And in older recipients of transplant, the mean functional status declines at least for the first 3 months and then bounces back in most parameters like instrumental activities of daily living and health status and performance status. And this occurs at all age groups, less than 60, up to 69, more than 70. However, if a person does not recover, start recovering by 3 months, they may not recover, and patient should be aware that transplant could be the final stressor and they may not do so well, even though the disease may be now controlled. So if I summarize it all, it is shown in this cartoon. So there's a factor, a resilience factor, the health of the patient, the motivation. Do they really want to undergo it, or are they happy, carrying on the way they are, preferring quality of life than quantity? And what is their degree of physiologic aging? They may be fit, they may not be fit. What is their ecosystem? In other words, do they have caregivers? How supportive is the family? Do they have the finances, the insurance? Do they have social support? So let's say, I had a patient who was the caregiver for his wife who was bedridden. There was nobody else. Well, there is no ecosystem. If we transplant that patient, this patient will die and the wife will die. So, that's a wrong patient to undergo transplant. What about the disease? If the disease is not in remission or there's MRD positive, they will relapse. There's no point doing a transplant. Can they undergo transplant or subsequent treatment, GVSD treatment? And finally, what are the transplant factors? Now, as hematologists, you all know, do they have a good donor? Will they tolerate the regimen? Can they tolerate GVSD prophylaxis? If they develop GVSD, will they manage the immunosuppression? And ultimately, as clinicians, we have to make a decision along with the patient and the family whether to go ahead or not. Throughout the journey, especially in the older people, they need counseling, not once, but many times before, during, and after. Caregiver support is essential. Bear in mind the home environment is the best place to recover. Sometimes, because we can't say no, we send our patients after transplant and engraftment to a rehab center where they don't know anyone, they get disoriented, there's no emotional support, and they don't do well. Those who go to their own home, in their own place, their own kitchen, their own living room, meet their friend, they do much better. And of course, they need help with physio, dietitian, psychological, rationalization of medicines. And each center should review what they are doing and modify and improve their clinical protocols. Whatever I'm saying may be completely irrelevant to your setting. I'd just like to share what we have done at our center. So we keep doing this. We keep trying to improve safety and changing our protocols. So this was the overall survival of patients transplanted from 17 to 18 compared to those from 19 to 20. And there was a significant improvement in overall survival and significant improvement in the non-relapse mortality, which went down. This was an ASH presentation by one of our fellows, and I'm just focusing on those 70 years and older. From 2015 to 19, I'd shown this earlier, the non-relapse mortality was around 48%, and now it is less than 30%. It's not yet been published because we are collecting more data. So coming back to case one, if you remember, it was a 65-year-old man with complex karyotype, TP53 mutation relapse, and then he again achieved remission. We took him for a second transplant, using reduced intensity conditioning, and deliberately gave only tacrolimus. We did not give ATG or even PTCY because we wanted some graft versus leukemia, and we were willing for GVSD. We used a new donor, he engrafted, and then we put him on maintenance azacitidine. You may say, why? because of the reasons I told you. He did develop chronic GVSD, skin, eyes, gut, mouth, lungs, which were controlled with a lot of medications. And even today, he's in complete CR, functioning independently, exercising and doing his work. And he's become a grandfather to 3, grandchildren. Despite the GVSD, he's very happy that he's still living. But all cases are not that difficult. Let me go to case 2. The oldest one we have transplanted, 76 years old, MDS, excessive blast 2, normal cytogenetics, got azacitidine, poor response, got AZA and venetoclax, and then achieved remission. I'm sure this is the kind of patient you see. Quite fit, not as fit as the previous patient. Very good family support. Timed up and go, 6.9 seconds. Very nice. Grips in 25 kilos. Anything more than 20 is fine. KPS 100%. So after a lot of counseling, and I was quite nervous, he's 76. He underwent transplant with a mud donor, used Flutrio, used what we use, PTCY with small dose of ATG cyclosporin, engrafted, full chimerism, and no GVSD, no complication. He's 1 year down. Very boring transplant, but I like when it's boring in transplant setting. So to conclude, transplant is the only curative therapy for many hematological malignancies affecting older patients. Certainly, there's a higher risk of complications in the older people, but with careful selection and personalized therapy, allotransplant can be offered to selected patients, and chronological age alone should not be a bar to transplant. We should keep our mind open. To start with, we should take the best case, not the most difficult case. And as we get experience, we could perhaps extend it, because as our population ages, and our facilities improve, we should not deny transplant to these patients. With that, thank you, and I'm happy for any questions.
So, thank you very much, sir, for your wonderful discussion, and the subject is very interesting. I think the transplant in the elderly, and you have been spoken all the aspects of related to the conditioning and the frailty and also the disease status. I think the lecture is fantastic. I think there will be a lot of questions will be there. So, but to the audience, you can also write into the chat box for the question. Anybody, any question? So, sir, my question is that so all group of the patient, you apply the same frailty score. Now it is only applied for these malignancies. Suppose the plastic anemia is there and the myelodysplastic syndrome is there. Also apply the same frailty score.
Yes, so very good question, Tufan. What we did, we are applying it to every patient, irrespective of the diagnosis and irrespective of the age. And I'll tell you the reason. Reason is, someone who's young, he may have aplastic anemia, but he may be completely bedridden. Now, we have had people, I'm sure you've seen, with one big skin lesion, with pneumonia, they can't walk, they're completely, unfit. Their risk for transplant is also high. So we use it for all, and that's why I didn't go into the details. We compared the applicability of this frailty scale, young and old, and actually it also worked in the young people. So it helps our decision making. That is only one factor in our decision making. We don't say because of that we'll say you're not fit or you're fit. We will also look at things like performance status, comorbidity, indication for transplant. But it does help, and we are using it routinely. Also, another reason is, if we say we will only do it for people more than 60, Today, a patient is 59. By the time he comes, he's 61. How do you differentiate? And then we will keep missing out. So we have used it as a standard of care, just like you do. We examine the heart and the lungs and the abdomen. Why not do this? It takes only 5-6 minutes, and it is good data which we are collecting. And I would say, to some extent, any center can do it. You can do it. And I may just add, the fellow who started it, she presented 3 papers. She then did a PhD based on that data. She's now a transplant independent person in Spain and has got a whole project going on there, has got 4 ASH oral based only on this. Something which is so simple, but there's no data on this. And to my mind, there's no data on this in India.
That's it. So there is a lot of 3 to 4 questions is there. Dr. Ashok Kumar is asking, when will you start maintenance chemotherapy in AML after transplant?
Okay, so in general, maintenance therapy, if we are using it, is given at around 3 months or at a time when patient has no GVHD and they are off immune suppression. So it could be, depending on the risk of the disease, as early as day 60. But in practice, I find that before day 60, it's very difficult because their counts have recovered, but they've got some problem. And then you add another drug, let's say sorafenib for FLT3 positive. Then they get a skin rash. Then you don't know, is it GVHD, is it the drug? So generally about around 3 months is what I would say.
Dr. Rachit Agarwal is asking that have you been using the PTCY universally in all mass sibling or mud transplant?
Yes, we are. So actually in our center, we use PTCY in all unless it is contraindicated because of cardiac dysfunction, for example. In the matched sibling donor, we use just PTCY along with MMF, and we use cyclosporin. You can use tacrolimus. For matched unrelated, we use double T cell depletion. That means we use PTCY and ATG with only cyclosporin. Now you will say that's too much, but the advantage is we stop the cyclosporin or tacrolimus within day 60 or 70. Okay.
Right.
And so related, unrelated, and haplo, same thing, exactly the same thing. So we use it in all, and there's a lot of data in matched sibling. It's better than using the CNI-based regimen.
That's it. So Dr. Hitavi is asking regarding the auto transplant in myeloma, what is the maximum age up to you can take for the transplant?
Okay, so firstly, I don't do auto transplants. I must confess, we are so narrow now. I do only allo, and my colleagues in the auto transplant do this, but they go up to 75. If they're fit, obviously if they're fit. But 70 is normal, but sometimes they'll go up to that age.
Up to the 75 years of the age.
Yeah. Some centers don't. Like, I'll tell you, it is very individual. So when I was in Winnipeg, for example, we didn't do any transplant initially over 65. But in Toronto, we were doing it up to 70. Now we've gone to 76. But auto was below 75. Above that, a bit scared. So it depends on your confidence and also how fit the patient is.
That's it. So anybody have any question or clarification regarding this topic? So thank you very much, sir, for giving this talk on the elderly transplant. This is a very new subject and the new topic. I think this will be very applicable for Indian context also because the elderly population has gradually increasing in India, and also the number of the transplant centers also increasing in India gradually. So on behalf of the ISHBT, again, thank you, sir, for delivering this lecture and taking pain for 1 hour to teach us in India.
Thank you very much, Tufan, and thanks to everyone for listening.
So thank
Bye
you.
for now.
We are ending here, sir. Thank you very much.